socially distanced, so we're limited on the numbers of members of the public that can get here, but I'm pleased to see that there's a couple of spare places in for the future if necessary. In terms of apologies, Paul Moore, the Director of Nursing, is on leave this week, and he's represented by Sue Modigan there, so welcome to Sue. We have Sri Andol, the Medical Director, who will be arriving but just a few minutes late. And then I want to welcome Doreen Wilkinson from the liaison service, who's going to give us a bit of an update later on in the agenda. I think everybody else has attended before. So let's get on with the business. First of all, we've got the official declarations and register of interest. Has anybody got any additions to declare to that? Okay. Then we've got the minutes of the meeting of the 27th of July. So, can I first of all see if anybody has got any problems with their accuracy? I won't go page by page because there's 16 pages, but I'll take shakings of heads as being that people are happy with the accuracy. So then in terms of the matters arising, we've got the update on neurology patient story, which is not coming till the November board, and then we were to provide an update on workforce and culture, and that will come later on in this meeting. So I think all the matters arising are addressed in the agenda. Okay. I have not been notified of any other items of business, unless anybody wants to do so now. Okay. So just to remind members of the public that we've had some questions submitted in advance, and those will be read out with their answers at the end. And there'll also be the opportunity at the end, assuming that we're not running over time, for members of the public to add any further questions they want to. So hopefully you'll have plenty of chance. Okay, so as I said, we've welcomed Doreen Wilkinson, who runs the Manx Care Advice and Liaison Service, and I think by way of the service and user story, is going to give us an update on what's been happening since it was launched in August.
Hi, good morning, ladies and gentlemen. Thank you for inviting me along. Represent MCALS this morning. I'm on the MCALS lead, and I work with two colleagues, Julia and Will Madrell. We've been running since the 2nd of August, so we're now in our 9th week, and we are doing very well. There's great service demand, and up to now we've had great feedback from service users. So I'll just give you a quick breakdown of what's the function of MCALS and what we've been achieving so far. So MCALS does listen and provides appropriate information to those who raise a concern, query or question. This is definitely a service that has been undeniably needed by the Manx public and our service users for a long time, and I'm very proud to be able to be involved in it. We are an identifiable service which is accessible to all Manx Care service users, their carers, friends, families and our colleagues. We also provide a comprehensive and consistent service across the length and breadth of the island, and integrated health services and those that are contracted by Manx Care. We aim to facilitate a resolution. The MCALS team liaises with colleagues within Manx Care where appropriate, and individuals from tertiary centres and contracted services. We hope to provide timely assistance to negotiate solutions as quickly as possible for the MCALS service users. And 88% of the time we are responding to that service need within 24 hours, which is a great response. The service is acting as a catalyst for change and improvement, and it is having a positive impact on our ability to reach out to those using our services. We will support consultations and improvements and changes to our health and social care services, and the service will provide a key source of information and feedback for Manx Care, and act as an early warning system by monitoring problems and proactively seeking experience from those who use the Manx Care services. So up to now, as of yesterday, the close of the day, we had 451 contacts from the Isle of Man community. We are monitoring and measuring the data through a basic spreadsheet as we go along, and pulling some formulas and data from that. I don't know if you can see the graph on the next slide, please. If I can just talk and highlight a few areas of concern. So we have identified 451 contacts, and the nature of the concerns are mainly involving Nobles Hospital. Now, this has grown from August. There was 142 contacts from the public, which has now risen to 258 in September as the close of day yesterday. So the service is growing, the demand is there, and service users are keen for quick resolution. And we are greatly involved in working in partnership with other professionals across Manx Care who are really gaining from our service and expertise in quickly answering those questions, getting the communication out to the public, and that's really what is needed and key really for the MCAS service. Some things that we've pulled out of the measuring data is the nursing and residential care home policy. As we all know, we had COVID lockdown during August, greatly affected our society, families, friends and colleagues. Worked greatly with the Department of Social Care, ASC, and we've worked well, haven't we, Sally, yes, together. That's been a great working relationship and has been greatly valued by both sides. We've had queries about Manx Care facilities in regards to travel on and off island, service users' concerns about the Manx Care telephones being busy, miscommunication between teams leading to patient uncertainty. And again, that's our role, is to facilitate that communication between the two and resolve it quickly and take that leverage of really the people that are on the front line doing the work that are extremely busy 24/7. MCAS has been wide-reaching. We've been contacted in regards to commemorative stones for people who have donated their organs, signposted people to face groups for support for rheumatoid arthritis and other illnesses and ailments. We are working Monday to Friday, 10 to 3. Phone lines are busy and we're quick to respond to the need. So again, I just would like to say that this service has been greatly needed by the Isle of Man public, and I will be the spokesperson. I've been supported heavily by Sue Wadaker, and I'd like to thank her for all her support, and Teresa in helping us get this service going. I want to see it succeed, and definitely going forward there's a demand for the service by the Isle of Man public, and I would like to lead with the voice for that. So thank you for listening.
Thanks for that update, Dorian. It's great to see such a busy uptake right from the word go. And can I just also ask you about your plans for the future? Because I think you do plan to expand the hours of the service and the scope of the service, don't you? Could you just outline that?
Yes, definitely the need is there Monday to Friday. 10 to 3 I think are pretty good hours. It could maybe go 9:30 to 4:30, so it's functioning during the daily working time. Where it should be, island-wide, should it go into the hubs, should it be at Nobles, is there going to be a central focus? I think that's what I'm keen to know and develop. Definitely there does need to be a core team, utilising maybe the volunteers for the future, in the hubs around the island for face-to-face contact. With COVID at the minute it's difficult with the volunteers, but definitely that's a must for the future. I think it's just deciding. I think we have enough data at the minute to know that there's definite demand for the service. It would be a great shame for it not to last, and it does need to move forward pretty quickly, really. It's great for the patients, great for the hospital, and for all of Manx Care.
Good, okay. Thank you, Doreen. Anybody else have any questions? Katie first and then Sarah.
Thank you very much, Andrew. So thank you for your discussion we had yesterday as well. That was brilliant, Doreen. And thank you for the materials. And if any members of the public would like to see, there's a leaflet there, and I'll just see that there. Nigel and I dropped into Radiology yesterday, and we saw one of these there, which was fantastic. But I think we need to do more in terms of visibility. Would you like to comment on what else you would like to do from being,
Yes.
visible?
I mean, we're a project for 6 months. Our communication was limited in the beginning, just due to being a project. Certainly we had a soft launch due to we didn't know what the uptake would be, and certainly I think in October we should go for a heavier launch, publicise communication more so around the island generally, not just with leaflets. We've met with other charities, we've met with outside agencies, and the word is out. People do know that it's there. general public have access to leaflets across dentistry, opticians, GPs. It's out there in the hubs as well. I've been keen to meet with as many agencies as I can, but certainly I would like to see maybe a bit of a harder launch in communication to the general public, newspaper, whatever we need to do, just to get the word out there of what we're doing and the success of it, really.
And how about you and your team being sort of stationed somewhere? Have you got any thoughts on that?
At the minute, I would, going forward, it's a difficult one really. There does need to be a core base.
Yeah.
Should it be front-facing? That's one to argue. Should it be at the front of the hospital? I would probably say yes, as in a core base, but definitely should go into the hubs once we get all the hubs open. If it should be outside the hospital, fine, but there definitely does need to be a central focus for the base of MCALs, for the administrative officers and the phone lines, and then outsource it if we can further down the line.
All right, thank you.
Sarah?
Thank you very much for the update. I think this is a really important development for Manx Care, and I think being open and available to those that are using the service is really important, and it was very good yesterday to have some really good examples of how you've been able to really provide reassurance to patients and their families about processes. So thank you for the work. My question really is about the future, and about, obviously it's a 6-month project. I think it's going exceptionally well. This is the standard that one would expect to see in healthcare and indeed in social care. And so I guess it's a question, Teresa, around how are we going to make the decision about the long-term future? And then I think all of the things that you've mentioned around a harder launch, more visibility, being more accessible to the public, in a real presence within the hospital, I think is right. I think we have been very clear that Manx Care is more than Nobles. So I think hearing you talk about going into the hubs is absolutely appropriate. But it's really just, when will the board be notified of the future, I suppose, Teresa, really?
Yeah, no, thank you, Sarah. I think what we'd like to perhaps do is understand the broader scope and the opportunity of MCALs, and certainly bring something back to the board. Probably, I would suggest the end of November. I'm looking at Jackie in terms of the process around the business case. I think where we've got the opportunity is this model can look quite different, and as Doreen has highlighted, the opportunity to draw in the voluntary and community sector more strongly into this model is the real unique selling point for Manx Care, given we cover the whole breadth of services. So I think if we look to sort of nail down what we would consider to be the future operating model of MCALs within the next month or so, with a view that we can develop the business case around what that looks like and perhaps bring to the board in November, we should aim for that. I'm seeing nods from Jackie.
So I'm writing it down.
That seems to be a sensible way forward, but I would give the usual caveat that I must do around resourcing, which will be a challenge for anything that we wish to do.
But I also do think, and I touched upon it when we were talking about the election coverage, we spent a lot of time communicating with our staff quite rightly as the priority once Manx Care was established. But I do think we now need to up our gear in terms of that broader conversation with the public, so they understand what Manx Care is doing, what's different, and what our priorities are going forward. So I think this has to link in with a wider piece of comms and engagement involving perhaps Marita in her new role and her new team, in order to sort of have a firm forward plan of that broader communication with the Manx Care public.
Thank you.
Okay, thanks. And Vanessa?
Yes, Doreen, thank you so much. It's music to my ears hearing about the work that you're doing. I'm planning on raising the issue about patient stories and patient engagement in my quality and safety and engagement chair's report, because I just think that one of the things that we need to do with that committee is strengthen our patient stories. And those patient stories are both when people have maybe complained, but also when they compliment Manx Care services. And I just think that what you're doing will be can represent a fantastic contribution to us pulling out some of those stories, because they really do illustrate what people are experiencing. So I'm sure that liaising with John and Sue and others will be able to get some really good stories coming to that committee. So watch this space, and thank you.
Right, so, sorry, do you want to come back, Noreen?
Yeah, I think just my final note is I think I have to say, I just really want to try and secure the future of MCALS, however it goes, to, you know, hopefully help the Isle of Man service users. I really do feel we have a good, strong set of data already, and we're only in our 9th week. And I would probably have liked to have seen a decision before November. I don't know if that's achievable, because I am aware the pilot ends at the end of January, and with Christmas looming, I'm aware of time constraints, so I think I just wanted to raise that point.
Okay, Nigel?
Thanks, Andrew, through you. Doreen, I completely congratulate you on your initiative, and we've sort of been primed because we had a great presentation from you yesterday, the non-execs, which was really good to understand it. I suppose my question is almost around decision-making, in that there's anecdotal evidence within the service, and certainly in the figures, and we'll certainly talk about it later on in finance, performance and commissioning, that it's not about what we're doing, it's also about what we're not doing. It's also about stopping things and redeploying resource to where it's really needed. And I think this is a classic example where, you know, deferring to my colleague over at Finance there, Jackie, we have to maybe look at the process for the speed of our decision making, because this is a super tanker, you know, and you spin the wheel now and in 2 years' time it turns around. And I think we have to be very slick and very speedy on our decision making where there is manifest evidence to support a particular project, particularly in this particular area, and give Sue and Doreen and her team that certainty to be able to recruit and to be able to plan and look at systems and look at how it's resourced going forward. And I think that's a very important point in this particular, but actually also across the piece.
Thank you, Nigel. So, in conclusion, Doreen, thank you very much for an excellent update, and this is a really valuable service. And I know we have to go through the formal evaluation in November, and I know that we have to identify the resources, but I think this is so important to the style of organisation that we want that it's really not conceivable that it won't continue, but we look forward to hearing more. So, thank you again. So, if we move on to my report, which should have been circulated to everybody. Delighted that controls now permit more frequent visits to the island. This is my 5th time, and I get the side benefit of being able to fill up my car with petrol during my visit as well, which is important. Thank you. We had a meeting with the Department of Health a couple of weeks ago where we were asked to outline what we felt we'd achieved in the first few months, and the rest of my report is quite a long list. Now, I really want to say that I know that we've got a very, very long way to go. There's a huge amount to do to improve the culture, the financial efficiency and the quality, but it is good to note that we can point to some quite specific achievements in the first few months, and those are the ones that are listed there, and of course MCALS is one of those. So unless there's any question on my report, nope, okay. Teresa's report has just been circulated to you now. Apologies for that, that was a bit of an oversight. So Teresa, do you want to take us through the highlights of that?
Yes, thank you, Chair. So my report just covers the main operational updates, communication updates and updates around partnerships. Just with regards to COVID-19, it's very positive that we have been able to step down to level 1 on our business continuity, which means we're able to move back to a single admitting unit, so a single AMU. However, we still have 5 patients in hospital with COVID, and we are starting to see that creep up a little bit. And we know community infection rates are just starting to rise, so we are keeping a very close eye on that. But it is positive that we have seen that improvement during September. The new Director of Nursing has provided the opportunity to place some fresh eyes on our nurse staffing establishments, and I know there's a paper further on the agenda which Sue will talk about in more detail. But this is a real concern that we need to ensure we have the right staffing establishments and the right skill mix at ward level. And therefore, the Director of Nursing has taken some urgent action with regard to securing that position and ensuring we have the right levels of staffing at ward level. And that has meant taking some actions around looking at other registered professionals who are currently working in other areas. The Theatre Improvement Programme has continues to be RAG rated green, and last week we had the Association for Perioperative Practitioners with us auditing our activities in theatre. They were with us for 3 days and they looked at a wide range of functions and actions as to how our theatres operate, look at some of our documentation. We've got some verbal feedback from that review, and the final report will be with us in around 2 to 3 weeks. But overall, the feedback from AFPP was incredibly positive. They saw some really good practice. They felt some of our safety features around team brief, debriefing following theatres, the adherence to swab protocols was all very, very positive. Their overwhelming assessment was that our theatres are safe. As ever, they always point out some areas where we can continue to improve. It's really, really important we maintain momentum around the safety programmes and the cultural programmes we are running in theatres. But I think as a sort of a benchmark position, when we are sort of 6 months into that piece of work, I think it was incredibly useful to have that external audit. Some good positive feedback, some areas for us to continue to focus and work upon. And obviously I will be bringing the full report and action plan of any areas where we need to improve back to the board in due course. The only other thing that I wanted just to flag from my report was just to recognise that from the 1st of October, Snaefell Practice will have 2 new partners. So Mary Rose Pritchard and Jeanette Qualtrough, who are both advanced nurse practitioners, will be joining Dr. Osbelt in terms of joining the partnership. And I think that's a really, really positive step forward around the sustainability of Snaefell Practice. So thank you to all involved for their hard work. I know Oliver was incredibly involved. Anne-Marie Cubban has done a huge amount of work to enable this to happen, and I think it's really positive that we've got advanced nurse practitioners taking up partnerships, and also we've got Snaefell on a more sustainable footing going forward. So happy to take questions on the rest of the report.
Okay, are there any questions? Right, apparently not, so let's continue. So the next item are the set of committee chairs reports, where you've got a sort of headline summary, but I'm going to go through each of the committee chairs in turn to highlight any points that they wish to. So first of all, for quality, safety and engagement, Vanessa.
Yes, thank you, Chair. Again, what I would like to just say is that the committees, as they develop, are becoming quite robust and quite supportive yet challenging meetings. And what I was particularly pleased that happened at the, well, not pleased about the content, but that the Director of Nursing raised in a very candid and open manner at the committee the issue of the safer staffing levels that I'll not go into because you've flagged them and we'll talk about them a bit more. But just in terms of the sense and feel of the committee is that the Director of Nursing felt comfortable and that it was appropriate to raise the issue at that committee, and that the committee agreed unanimously that the issue would be escalated to the board. And that's how subcommittees of any good board should work. So I was really pleased about that. The other things that we talked about were the incident reporting and learning and a draft report. And I think we've talked about we need to be as well even more robust about does learning really take place. So that's ongoing for us. And of course I've already mentioned it with related to Doreen's presentation that we also would like to get a bit more robust and smarter on listening to patients' stories and you know, complaints and compliments. And I don't think that it's the role of the committee when listening to any complaints that we pick them to bits, but that what it does, it gives us an illustration sometimes of themes of where people have got concerns, and that again is the sort of thing that we can then escalate to the right senior managers. So I think that that's probably the main issues that came from that committee. So thank you, Chair.
Thank you, Vanessa, and I'm glad that we will be having this separate report on nurse staffing later, because it's a matter of serious concern. So I can move on to the People Committee now, Sarah.
Thank you. I would like to start by saying it was a great disappointment to the committee that we didn't have a staff story, and we've had two previously, and we've given feedback to those members of staff who have come forward to thank them. And it's a priority for us, really, excuse me, that we do hear from staff, and really echoing Vanessa's point there about hearing from patients. It's not for us to receive those stories and necessarily get involved in any resolution, but really to hear staff's experience. And so I'd like to take this opportunity to say that the committee would really welcome members of staff coming forward in a very supportive manner to tell their stories. We took a paper on the staff recognition scheme, and we really do, as I said previously, at the board feel that this is really important, that this is actioned as soon as possible for staff. There are some concerns about vacancies, but we have that later on our agenda, so I won't say any more about that. We're delighted to see the workforce and culture work really gaining momentum, particularly in those key areas, and Teresa's already mentioned the important work that's going on in theatres. And just to note, pay remains an issue, and I know that's also on our agenda later.
Thank you. Okay, so we'll now move on to Katie and the digital report.
Thank you, Chair. Yes, so this was quite a busy agenda actually, and there's a couple of things I'd just like to draw everyone's attention to. The first thing is that those of you who know me know that it's important for me to understand how IT is enabling what we do as an organisation, and to that end I'm very pleased to see that a clinical information steering group is being set up, so that's brilliant. And I've seen the terms of reference to that as well, so that's very good. So what we want to try and do is get people who are using the IT, or the lack sometimes thereof, in their day-to-day jobs, and understand how it is that we can help them. How it is that we can help them do their day-to-day jobs. So IT is about enablement, it's about making sure that we can get the best result for the end patient, and so that's what the CIS-SG is all about, so that's very good. A couple of other things we talked about: Manx Care Record. There's a steering group being put together to direct that programme. That's obviously an extremely critical part of what we're doing, to make sure that we can have patient records in one safe and secure and central place. That will be established, including the Information Commissioner, which I think is important. There needs to be a good relationship there, so that's very good. And the only other thing I wanted to mention is that the business intelligence piece is coming along well. And you'll see in the pack there's something called the IPR, which is sort of stacks and stacks of data, which at the moment is produced manually. By the end of this month, sort of, this week, we'll start to produce some of that automatically, and the intention is eventually all of that will be automatic, and it'll reduce the burden on the staff for producing the data that we need to see to make strategic decisions.
Okay, thank you. So we'll move on to the next report, which is Nigel and Finance, Performance and Commissioning.
Thanks, Andrew. Through you, good morning, everybody. So I'm reporting on the meeting of Finance, Performance and Commissioning held on the 20th of September, but clearly colleagues know that a massive amount of the summer period was taken up by the preparation of a budget for submission to Treasury going forward into financial 22-23. And it's interesting that we are looking that far in advance at finance, which I think is quite interesting, given that we're only 4 months old at that stage. Quite a challenging piece of work, and I congratulate the team on what they produced. So I don't intend to repeat the main points in writing that have been submitted in the pack, but perhaps just to amplify one or two issues and pick up on a couple of themes I'd like to draw your attention to. And I hope that that will set the scene and perhaps bring into context some of Jackie's comments in her FD's report, which we'll get to. I think it's fair to say that our understanding has been massively assisted by a series of really helpful meetings we had yesterday with team leaders, and I think we certainly appreciated it as non-executive directors, and I hope the team appreciated it, and certainly the feedback we got from our visibility was really encouraging, I think, and very useful. Look, it will be no secret to colleagues that there is a wall of deserving need in our community, and it has a knock-on effect on finance. The management accounts that we're considering at the moment to the end of July indicate a small overrun in costs. And clearly it's imperative that we get a handle on that if the trends continue through to the year end. This, of course, highlights the needs for timeous visibility of the figures. And it'll be no secret to my colleague at Finance that I've been banging on for monthly accounts following the accounting reference point. So, for example, I think we need to be getting to September figures by the end of October. And certainly that is very much on our agenda so that we can see what's going on in the numbers and react to them. And there again comes my theme of speed of decision making so that we can actually have an effect on this massive machine that will grind away to the year end. The challenge of an overrun makes it very real, I think, but there is also an opportunity. And the opportunity is that we have already identified areas for cost savings. The cost improvement plan is well advanced, and Jackie will report on that. And I think also it's also about, as I said, talking about Doreen's presentation, this is not about just what we do, but also about what we don't do. It appears that there is clear evidence in the business cases for stopping some things that we do, and there is clear agreement at executive level, both within the operations division of Manx Care and also the strategic division of our stakeholders. So there is agreement about what we should be doing and what we shouldn't be doing. However, that is taking too long to implement. And I think we need to pay attention to that, perhaps through the partnership board, that we need to speed up that process of decision making where folk are in accord. I think that's a very important thing to learn. This overrun has not manifested itself in the last 6 months. There are real systemic issues that have grown over a period of years. And notwithstanding Jonathan Michael's representations and recommendations, we must not underestimate the fragility of the opening baseline position, or indeed the effort required to change direction. It will take time, and in many cases we will have to invest ahead of the curve. We will have to spend money to save money, to optimize cost, to optimize unit cost, and improve our sustainability. Jackie will drill into the details of employment costs and drug costs, and the high cost of non-full-time staff, agency and locums, and the pressure that this creates, but also the fantastic relief they're clearly bringing to an understaffed service. So the word is recruit, 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 and recruit some more, offering hopefully innovative solutions to enable skilled people to join the service and stay with us, and at the same time grow our own, particularly in nursing and midwifery. That is coming through loud and clear. I said it's not all down to COVID, but my word, this has had a massive real and knock-on effect. Our teams are tired and weary, and we have been given so much goodwill across the piece to maintain the service, but that will not and cannot last forever, and we need to recognise that. Leave must be taken, training and support must be given. It is unrealistic to think that colleagues can get home after 12 hours on the front line and then sit down to do CPD or read 100 emails in their inboxes. Very important indeed. So your committee also received excellent reports on contract compliance, where there is much opportunity for review and change, and also on restoration, particularly on the waiting lists, excellent reports and related matters. And I have, and I think the committee has been immensely impressed, and this echoes Vanessa's thoughts, I think, by the openness, engagement, enthusiasm and commitment by senior leaders. And I perceive that although we're not without challenge, it does bode very well for the future. Thank you.
Okay, so well, thank you to Nigel and all of the committee chairs for highlighting really the achievements, but also the many challenges that we're facing, whether they are...
Chair of the Mental Health Act Committee met yesterday.
It met yesterday, didn't it? I beg your pardon, it's not on the list.
Report.
Absolutely, please, Andy, over to you.
The committee the principal part of the business was examining a report from the Mental Health Commission visit to one of the premises. Obviously, there were some things which could be improved, but actually the committee chairman had said that this was actually one of the most positive reviews that they had undertaken in the last 4 years, which was very encouraging, and actually joined us for the meeting and further offered to then include some other items in further reviews to help us understand further how our performance was, which was very good. We've also managed to secure a Royal College of Psychiatrists accredited training programme for our psychiatrists. That's just going through the commissioning team at the moment, but it is a mandatory requirement effectively, so we expect that will pass through commissioning fairly quickly. And finally, the Mental Health Service is working with the Mental Health Act tribunal teams at the moment because their guidance documents require updating. So they're working together to draft the new guidance, and then it will be reviewed together, and then it will be disseminated to all the stakeholders for comment.
Thank you, Andy.
Thank you.
Apologies for getting your committee, which I was at yesterday, so I should have remembered it. Right, now, according to the agenda, we should be breaking for refreshment, but I think we're quite a long way ahead of ourselves, so I'm proposing to carry on till about 20 past 11 before we do that. So the next item then is Oliver and the Integrated Performance Report. So over to you.
Thanks very much. As Katie mentioned, this report is undergoing quite a bit of change and automation. As you can see here, it's quite a weighty document containing lots of data and also narrative from our care group leaders. And I'm hoping people who have attended these meetings before will see quite a significant improvement in the information that's provided by each care group manager. So I just wanted to go through a few areas of note, really. This report covers the period of July. It's worth noting that around the middle of July, we did go into COVID escalation situation at the hospital. So our wards reconfigured to cope with an increase of COVID cases, which meant that Ward 1 was taken out of general ward kind of purposes and changed into a COVID only. That had an impact across quite a number of the areas within the hospital. We had to significantly increase the number of electives that we were cancelling, so that meant that we were pretty much had to suspend the entire elective orthopaedic programme. That only came back online a couple of weeks ago, and other less urgent surgeries were cancelled, unfortunately. That had an impact on theatre utilisation, which reduced and obviously increased the number of cancellations both within theatres and had an impact on our waiting lists. We also saw an increase in our length of stay of our patients across the hospital, and this is primarily due to the impact of COVID on the social care sector. So that's both the impact of people catching COVID who work within our nursing homes, our care homes and the domiciliary care sector, but also some outbreaks that we were starting to see across nursing homes or care homes, which had an impact on our ability to discharge patients. So that's kind of a bit of a context of some of the areas that were seem to be deteriorating in performance in July. On a more positive note, from an ED point of view, we have seen month on month a reduction in ED attendances. So ED attendances were down from an average 110 earlier this year to around 80 per day. Our 4-hour performance, so the percentage of patients who attended who were seen and treated and either discharged or admitted within 4 hours, increased to 79.3% in July, and that was seen by a further increase in August to 80%, compared to a backdrop of an average within the NHS in England of 77%. So that's a really good kind of benchmark in terms of our performance. And in terms of comparison, our performance in August 2020 for 4 hours was 72.5%, so we've increased by 7.5% our performance, which has been great. From an ambulance point of view, there we have seen quite a significant increase in 999 calls, 34.5% increase in 999 calls from July 2020 to July 2021, and an increase of 18.5% from June 2021 to July. So that is quite a considerable increase that we've noticed. Again, keeping from a positive point of view, mental health services, we've seen a stable caseload throughout the year. We've seen a significant reduction in length of stay within Manannan Court, and the rate of people who are followed up within 3 days of discharge from Manannan Court has remained above 90% throughout the year, which is a really good position. So that's all of my highlights, Andrew.
Okay. Just before we open up to questions, Sally, did you want to cover anything from the social care side of things?
I need to say that we're still not content with the KPIs that we've got, and actually as we sit here, there's a group meeting to actually look at further development of our KPIs. Children and families are slightly more mature than adults, but we know we've got a great deal of work to do.
Sure. Okay. So if I can ask you first question, Oliver. When Nigel was talking about the finance report, he talked about trying to get it more timely and contemporaneous. This is the July performance report, and we're nearly in October. Now, I know that this is being automated, which will help with that. Can you say when we would hope to be able to be reporting on the previous month rather than the month before the previous month?
I might need to ask Richard about that in terms of, I'm presuming that once we have an automated system, it will be able to extract the information pretty much from the day one of the previous month. So the 1st of October, be able to extract the data from September, presumably, which we'll then be able to send around to care groups. So I'm guessing that once the new automated report has been tested and is of adequate quality, considering that these meetings tend to be towards the end of the month, we would look to be reporting at this meeting for the previous month.
Richard, do you want to add to that?
Oliver's absolutely right, and as Katie said, the automation of the integrated performance report, phase 1 of that is due at the end of this week. Phase 2, hopefully within about 6 to 7 months' time. But as Oliver's said, once you get to month end, at that point, because it's manually created, those teams have then got to go and meet with the care groups. They've got to manually extract that data. They then need to turn that into the graphs and the intelligence that you see in these reports. They then need to go back to the care groups to make sure that they've interpreted them correctly. They then need to go through the various committees for approval before they then come here. And as Oliver said, once that's automated, we'll be able to take many weeks out of that process.
That's good. And then just one more from me, and I mentioned this before, this report does get better every time, but we still aren't able to show the year-on-year. You reported some verbal year-on-year reports, but they're not in here. How soon can we have year-on-year data?
I think that's, again, will be solved by the automated. We can design the reports based on the data that's within the IPR system. You know, we've been running the IPR for since April.
Yeah.
And so there will be that historical data within the system. So, and care groups will be able to add their benchmarks, so research their own benchmarks, whether it's similar jurisdictions or the benchmarks within the NHS, and also add those in to that data, which again is, I think, is...
Both of those would be very helpful to have benchmarking and year on year. Teresa.
Thank you. Oliver, it is encouraging that we're seeing DNA rates reduce month on month, but it's still quite high. I was just wondering, is there anything being done specifically, or are there any specialties which your performance and delivery group are targeting?
The issue of DNAs is going to be covered in the development of an access...
Can we just... I'm sure all the public know what's being referred to here, and it's nothing to do with sort of the physics.
Cellular structures.
Did not attend. People who didn't show up for their appointment. Sorry, carry on. We do have an issue around DNAs, and that the main reason behind that is the way that we book clinics. So we book clinics incredibly far in advance, and so people get their appointment letter for potentially an appointment in 9 or 12 months' time, which is not the way, because even the most fastidious person in terms of their planning could potentially, particularly if it's the following year. So what we're going to be doing as part of our developments, as part of the access policy, is to operate our appointment system much less in advance. So based within the essentially how the UK runs it, so that we would normally issue appointments around 6 weeks in advance, and that is to coincide with the mandatory leave booking period for consultants. It's pointless us booking appointments way in advance, because we know that probably for about 10 weeks out of every 52, a consultant will be away, and if we book their clinics for when they're going to be away, then it just means that patients are inconvenienced because of cancellations, and I'm sure lots of people around the room who live on the island experience frequent cancellations. So what we will be doing is to bring the appointment booking process to just less than 6 weeks, so that we know in 6 weeks' time whether a consultant will be here or not, so we can then be confident that the clinic will be going ahead, and then we can book all the appointments and send those much further in advance, and much less in advance, sorry. We're also looking to try to revitalise the SMS messaging reminder service. We had hoped that we might be able to improve that as part of our data collection around the vaccine programme, but unfortunately that hasn't been possible. So we're going to have a think about how we can improve the uptake or the opting in of people who within the SMS messaging system, because probably only about 30% of the adult population has actually opted in. So I probably need to speak to Richard to think about ways of us being able to do that, because it's a system that exists quite a lot in the UK within the NHS, and then most dentists and hairdressers and all kinds of people have SMS messaging systems, so it's something that we're looking to introduce here. Thank you. I look forward to seeing that. Sorry, Teresa.
No, I just think that is really important, and I think it gives us some good discipline, particularly around our medical staffing and being able to adhere to the 6-week policy change. I think the third component of that is just to ensure we have the ability for people to ring in and get a good response in terms of wanting to change their appointment or notifying us that they're not able to attend. Because I suspect that possibly doesn't help the public keeping in touch with us or letting us know if they're not able to attend. We know our phone lines are busy just from the feedback that MCALS has been giving us over the last 9 weeks.
Okay, next is Vanessa.
Yes, thank you, Chair. This paper already was discussed in quite a lot of detail at the Quality, Safety and Engagement Committee, so I feel a little bit of a sense of deja vu. But I just really wanted to comment at this board some of the things that were said, that there's a certain degree of information that we get through this paper where that raises a bit of a so what question. So why have we been given this information? Because it doesn't necessarily tell us anything much about quality and safety. And just to illustrate that, I mean, I've just glancing at page 23, which is ambulance services, about the geographical spread, and I think probably we instinctively know that, and it's not telling us anything about people's experience or or how that was for them. So that's just one thing that I wanted to raise. But then there's just a couple of other more specific things that I'm not sure I did raise at Quality Committee, having the second chance at looking at this. And one is on page 48, and that just raised a question maybe for Sally about re-referrals to children's social care. And I just wondered about a comment on those re-referrals. I'll also give you my second question as well, which is on page 51, but I'll come back to it if you want, where it's around safeguarding. And it says 37 referrals have been raised within safeguarding. 24 of these were relating to safeguarding concerns, and all were discussed with the IRD hub, and 9 went to stage 2 of an inquiry. I just wondered what the difference was between the 37 and the 24, because they're all safeguarding concerns. So they're my two more specific questions.
Sally, I think they're both for you.
Yeah, in terms of the children, the re-referral rate is of concern. We're looking at, between 40, well over 40% in some areas. So we've been doing some work to file audit to see whether they are the people that, or children or young people that have not actually gone on to a rates assessment in the first place, or whether that's been closed down too soon. But there's still a lot of questions around that. In terms of the adult safeguarding, could you just repeat your question, sorry, Vanessa?
Yeah,
because the adult safeguarding is one.
It's maybe just a point of clarification, Sally, but it says 37 referrals have been raised within safeguarding, but 24 related to safeguarding concerns. And I suppose I just thought that 37 referrals are all concerns, or maybe some. Just a bit of explanation.
Yeah. What that is, Vanessa, is actually the referrals that come. So by far the biggest number of referrals we get of safeguarding concerns, and that's usually when police officers have attended a property, and they may not actually have. A tangible sort of concern, but generally they may be usually in domestic violence, or a parent may be under the influence of alcohol or drugs, so they send in a safeguarding concern rather than actually a referral for us to do some digging around and checking out.
Ah, right, so it's a difference in wording between
so it's where
a concern and a referral.
Yeah.
Right,
yeah.
Okay, thank you.
But it still doesn't answer the so what question, so they do need to be looked at. And adult safeguarding is an area that we're doing some really focused work on at the minute, because we're not where we need to be.
Okay, thank you.
Okay, thank you. And I think, again, for all involved in preparing this report, I think Vanessa's challenge about the so what is important. Now, there is a lot of narrative in the report now, which does attempt to do that, but it can always focus more, I think, on the, what we should be pleased with and what we should be worried about. Those are the main things, I think. Andy, I think you're next.
Yeah, I did have a question, which is about the integrated community services. I know I raised this previously. While I agree, things like the so what questions and the highlights, but equally, this can show some of the lowlights. And this, for me, stands out as a particular lowlight, and I want to know what action is being taken, because according to this, practically every referral misses its target to this service. Now, it's being moved because it doesn't comfortably sit in one particular place, but nevertheless, it looks to me as if it needs some urgent action.
We are recruiting into the CATS team. We had to suspend a lot of the services that CATS provide during the COVID, particularly during the lockdowns. And so that created quite a significant backlog. And combined with that, we did have a couple of people retire. So the service has been, which is a reasonably small service anyway, is about 15 individuals, 15 OTs and physios. But we've now recruited, and they are started, or they have both already started. 2 people from off island, so the service will be getting back up to full strength. the service has reconfigured some areas, so it's reduced the number of kind of group sessions it does to focus more on the domiciliary services that it provides. But in terms of the report, we've got the heads, we've got the interim joint heads of therapies and podiatry, which is Kelly Gulland and Francis Butler, will be able to provide a more up-to-date version of that of the situation in next time's report. It has just that particular narrative has just fallen through the cracks.
I'm not too worried about the narrative on it. It's just actually just looking at the hard numbers. Just says, look, there's a service that's really in difficulty.
Yeah, I think as you said, it's a combination of workforce challenges and just catching up from COVID.
So you think it will naturally
the service
up soon?
The service prior to COVID was hitting all of its targets, so I've no reason to think that without a bit of catching up that we'll get to that situation again soon.
Great, thanks.
Thank you. Nigel.
Andrew, thanks.
Sorry, Sri, I beg your pardon. I'll do Sri afterwards. Nigel.
Okay, thanks, Andrew. Through you. It's really a general comment about the performance, sort of addressing the so what question, really, Vanessa. And we had a very useful presentation at Finance Performance, clues in the name, and Commissioning Subcommittee from the IT division about the IPRs coming forward. And I thought a very telling and interesting comment made by the senior leaders, who said that we are now producing for you the data and subset and statistics that we know you have needed for the last 5 years. And I thought this was an amazingly positive and exciting comment, because it goes right to the heart of what we're trying to do as a board, and that is to empower and trust clever individuals who know their business, know their service, and back them. And I thought that was very good indeed. And the other point I wanted to make is that I didn't want to appear to be Mr. Angry over the timely production of these statistics, in that, there is a balance between getting the timing right of producing the statistics quickly, but also of validating their accuracy and validating their interpretation. And therefore it's absolutely key that when these figures come out, and that goes for finance as well, that the leadership team is given sufficient time to look at and interpret those figures, and, if you like, put them into context and tell the story around them. So I just wanted to make that point. Thank you.
Okay, thank you. So, Sri.
Sorry, Chair, I just wanted to kind of bring to your attention and to the board and the public as well a couple of important points about the IPR report itself. I think it's to be quite borne in mind a couple of things here. The first bit is that the IPR statistics that are presented there are several levels of targets, as we know. That one is a hospital level, one is an integrated system level, and another one is a national and a UK level. So I think it is important to know that Manx Care is an integrated care system. Not everything is about the hospital, and it's a bit more than that. So I think that's the first bit I was going to say that. The second bit is I don't think that we should be too fixed on the targets. I think it would be kind of foolish of our organisation to just fix on the targets and miss the point as it was. I think it is important to notice what actually improvements are there and what care is being delivered. That is the key bit that to be noted. And I think when people try to infer from the targets, I think this is in development. Just to remember again, during COVID phase, a lot of targets of our urgent emergency care has been not monitored anywhere else in UK, but we are still monitoring it. So that doesn't mean that I'm not saying that we are in any way superior or any way better than UK, but I'm all saying is that we need to take it in right context where we are with it. So I think it's for everybody else to not to focus on it. These are all iterative. These things will change. The new urgent and emergency care targets are also changing. So there are a lot of changes that are coming through the picture. So I think to focus in a narrow spectrum and say that is the level of improvement, just looking at a few graphs, is probably not the best way forward.
Yes.
Thank you.
No, that is a fair set of points, Sri, but targets, people love and hate targets. Politicians love targets because they can see that they're doing something positive, they're setting a target. And then, of course, if the target is achieved, then that's a great credit. But equally, I think A&E is probably one of the most controversial targets there is in the whole of the NHS. And we do know that they are the bane of people like Oliver trying to meet the A&E target. But actually clinicians working in A&E have welcomed the fact that there has been such a high-profile target, because it's meant that they've had attention and resources and support. So it's a more complex picture about targets, isn't it? But personally, I think that we should be looking to have quality improvement targets wherever possible, because those are ones that people really can buy into completely. So, right, any more questions about the Katie?
Firstly, my compliments on the ED performance, because that is better than, for instance, Oxford, so that's fantastic. My question, though, is about the recovery from for the elective backlog. And I note that there are a couple of outsourcing contracts that you are in the midst of negotiating, 18 weeks and Medifer. My question is, where are those companies sourcing their staff from? Because there is only a finite amount of resource here and across in terms of where these staff are going to come from, because absolutely everybody is trying to improve their backlog now. Mm-hmm. So how confident are you that there are staff to be had?
Well, I'll cover the restoration bit in my update a bit later, but in terms of that specific point, because it's not covered in that, the 18-week support uses a principally weekend resources. They've given us our assurance. They've given us their assurance that they will be able to. They have a stable enough staff base to be able to provide staff for us. They are an incredibly successful and high-profile and well-respected company in the NHS who does a lot of work across the NHS around delivering additional capacity within hospital buildings rather than outsourcing it to private hospitals. So I, through their assurance, have no worries about it. From a Medifer point of view, it is normally consultants that work on generally their downtime. At home, they have the Medifer system, which is basically a portal into our system so that they can access our healthcare records, our Manx Care, or a subset of the Manx Care health record that is in relation to their referral. That's all been or in the process of being signed off by our Information Commissioner to make sure that all of those checks and balances are in place. But again, they have a wide pool of consultants, differing sizes based on the size of the specialty. But again, they have provided us their assurance that they don't have any concerns about consultant capacity from that point of view. And so, but we are, because the funding, the 1.8 million that we've been given as part of the recovery and restoration business case that we originally submitted, that has a hard end on the 31st of March, so the end of the financial year. So we've been very clear to both contractors that is we expect the size of the contract to be delivered by the end of the financial year, and they've provided their assurance. But I do get your point that, I think I saw in the news this morning that there's, I think, 5.6 million people on NHS waiting lists now, which has gone up from 3 point something when I wrote the business case back in April. So, the NHS is still accruing quite a significant, despite the several billions that have gone into their elective recovery, they're still accruing significant amount of people on the waiting list faster than they can clear them. So, there is a huge demand for additional capacity, but I'm confident that we've developed a good enough relationship with both of those suppliers that they'll be able to provide us provide us what we've asked them to commit to.
Terrific. And I mean, there are still 6,500 people with COVID in hospitals in the UK. So they're going at it both ways at the moment. So I expect there will be some pinch points. We just need to be aware of that. But thank you.
Okay, so I think we can now move on from the integrated performance report. Just to remind members of the public that the way this agenda is structured is to follow really the priorities of the organisation. So first of all, we have a section on governance matters, then we have a series of updates, of which the integrated performance report is one, and now we move on to the 3 priorities that Manx Care has set. So this is improving patient safety, improving culture, and improving financial efficiency. So let's take the first of the papers on improving patient safety, which is breast services. So back to you, Oliver.
Thank you. So this is a relatively brief paper just outlining our actions that we've taken over the last few months to address the underperformance around breast cancer. So we, as Manx Care and the HSC prior to Manx Care, have a target of 93% of patients being seen by a specialist within a hospital within 2 weeks of being referred, if the referral is suspected of cancer. Now we have a cancer services team that monitor that and work with services to respond to any deviation from that. One of our biggest cancer services on the island is breast cancer. Due to the pandemic, we suffered quite significant workforce challenges within the breast cancer, the breast services team. The breast team work very much as an MDT, so they, unlike most other services within the hospital, they work as a team of surgeons, breast care nurses, radiologists, and mammographers, and they all basically have to be in the clinic at the same time in order for the service to work, because the service that we offer patients who are referred on a 2-week pathway to breast, we offer them what we call a triple assessment. So they're seen by a surgeon, they're seen by a radiologist, and they also get a mammogram as well. And it's that triple assessment that enables us to be able to discharge patients on the day if they don't have breast cancer, or as soon as possible if there needs to be a biopsy that needs to go to histology, or they're put on the pathway, the breast cancer pathway, if they have a breast cancer. So any removal of any of those members of the team does have an impact on our ability to run the clinics, and unfortunately the pandemic has had an impact on that, which has resulted in our average number of people being seen within 2 weeks on average was 36%, but our low point, which is January this year, went down to 21%, which is an equivalent of a 9-week wait, which is obviously significantly more than where we want to be. So we've been working across the MDT to increase our capacity both within the hospital.
MDT?
Oh, MDT, multidisciplinary team. So that's, as I mentioned, the surgeons, radiologists, oncologists, mammographers, histopathologists, all working together to increase the capacity of the service on the island. So we've extended the triple assessment clinic on a Wednesday to increase the number of appointments available. We've introduced an additional Friday morning clinic. We've introduced an additional Saturday morning clinic for under 40s, because the under 40s don't need a mammogram, so we don't need the mammographers there, but we do need a radiologist and a surgeon, and we've been able to facilitate that every other week. We invested in additional locum staff in order to facilitate that, to provide the additional capacity. What we also did in order to supplement our capacity on island was that we worked together with Spire Murrayfield, so that is a Spire, a private hospital, independent hospital in the Wirral, who provided several clinics for us. So we arranged for initially there was 5 clinics organised, and so we organised transport and everything. Basically everyone who was referred, who was where their appointment was more than 14 days in advance, we offered all of those patients the opportunity to go over to Spire. 27 patients took the opportunity to go over and be assessed by the staff there. That was Miss Anne Tansley, who is a close, she works quite closely with the Manx breast unit anyway, because we refer a lot of our reconstructive cases over to her. She normally works in Liverpool Royal Hospital, the Linda McCartney unit, and Dr. Asha Sivaram, who is the consultant breast radiologist. And the feedback from all 27 patients was overwhelmingly positive, both from a actual kind of quality patient experience, but also the arrangements around patient transfers, etc., because obviously that can cause additional stress if it isn't properly sorted out. So 27 patients went through the Spire system, but all of that work has meant that we are now booking patients within the 2-week wait. So if somebody is referred today, they will be seen within 2 weeks, and we are maintaining that 100%, which is a great achievement from all of the team that has put in additional work to make that happen. From a sustainability point of view, we are in the process of recruiting a second consultant breast radiologist, and we have a couple of really good applicants within our, the advert is still live, but we already have a couple of really good applicants who have applied for the post. We're also shoring up our surgical service, so at the moment we have 2 consultant breast surgeons working within the service, one of whom is working full-time and the other one is working 1 week in 4 to supplement the breast reconstruction side of things. We're also in the process of recruiting a second breast care nurse within the service to work alongside Helen, who is our full-time senior breast care nurse, and we also have a specialist nurse working in that area as well. And we're also about to recruit an additional mammographer. So that just means overall we're increasing the capacity of the service, so we are more resilient to workforce challenges, and also we have the ability to flex our capacity upwards if we do see an increase in referrals. So where our referrals exceed our normal capacity, we do have the ability to put on additional clinics so we don't end up in this situation again. So I think that's it.
Thank you, Oliver. Teresa.
Yes, it's I guess mainly a comment to supplement Oliver's report. So, and we brought an update to the board a couple of months ago on this when we were just embarking on this. Manx Care is very committed to delivering breast services on Ireland. I think that's the first thing we must clarify. And this interim measure was taken whilst we put those sustainable arrangements in place, which Oliver's just described. We worked really closely with the breast cancer charities on this and had their full support for the actions we took to offer ladies the opportunity to go to Liverpool. And I think it's worked really, really well. And the fact that we are now back down to 2 weeks for the first time in over 18 months is great news. I think the further work that we need to do is around getting the messages out around 2 weeks and stressing the importance that if ladies are referred on a 2-week breast pathway, they really do need to engage, because we're now starting to see choice being exercised and people deciding to delay it more than 2 weeks. So we are now in a position to offer 2 weeks, but it is really important via the referrer, the GP, and via the communications with the public, we really impress upon this is a cancer pathway and there are reasons why it's a 2-week standard and there are benefits from being seen within 2 weeks and early, and we give that commitment to those ladies.
Thank you. Doreen, yes.
Just from an MCAS point of view, the feedback that we've had from service users, again, yes, it was great work. They were given the opportunity to go across, and yes, some did decline that service and opportunity, which then put them outside of the 2-week wait, which is a great shame, really. And I'm wondering what could be done to, you know, like we would do from MCAS point of view, to provide that assurance to the public about the travel, because that's really what's the calls and feedback that we got. They didn't want to travel. They didn't want the problems that come with travelling, the worry of COVID and everything else, which is a shame. And I'm wondering what we could do to strengthen that.
So I think,
can you give us an answer to that as well as a question?
I think it is a difficult one, because again, at the end of the day, if they don't want to travel, they don't want to travel. But again, like you say, they have to buy into this 2-week pathway. And if it was me, I would go. But for somebody maybe with mobility issues, worried about travel, how can we put that assurance in place? You know, do we go the extra mile and say, well, actually, we will get you a taxi, you know, from your house to the airport, or what can we do from a patient transfer point of view to make it a bit swifter when you think that money has gone in and that initiative has gone in? It's a great shame that we didn't have a higher uptake due to maybe people and service users not wanting to travel. So I think really maybe, look, it's very fortunate we got that opportunity. It was a shame that some people didn't take it up.
Yeah, sure.
I mean, our aim is to provide all ladies with the opportunity to remain on island and have that capacity. I think the Spa and Murrayfield was particularly helpful at a point in time to clear the backlog. It's the sort of thing we would always want to have in the background should we have any peaks in demand, to be able to provide that sustainable delivery of the 2-week wait standard. I do think there's a public message around the importance, you know, it's the public health advice around breast care, isn't it, as well as the importance of taking up appointments. But I do think this is where we can do some more work with our GPs on when they're making that referral, really impressing upon the importance of taking up the opportunity of appointment at the earliest opportunity rather than delaying care. And I think, you know, we've never been in that position of being able to offer a timely appointment, and now we are, and working on sustainably achieving that going forward. So that's our commitment, and what we're now asking is for our referrers and our ladies who referred into that service to work with us to be seen within those 2 weeks, because we now do have the capacity.
Sweet, you wanted to come in?
Yeah, just wanted to ask Oliver and Teresa as well. I know that we focus more on the 2-week waits and things, but actually the breast cancer pathway is a bit more than the front end. It's the follow-up as well. These are changing. I like to think that in next coming years, couple of years, this will be PFUs, which is the patient-initiated follow-ups. They will have direct contact to the oncology team and the nurse-led pathways that will change the way the people are being followed up. So it is not just the front end, the follow-ups are also an issue. So this will follow it up as we go along. Yeah.
Andy?
My point is largely financial, Ollie. So your report, you say you're securing additional funding for mammographer and one other post at least. I don't recall seeing that in any business case in the finance committee, or because obviously we're right on the edge with our budget already, and I don't remember seeing funding being moved across. I don't know if Jackie can answer that, because obviously we know we've got a new consultant costs X, but the service around the consultant costs 2 times X.
I know at the very outset of the Manx Care Go Live, as we were doing our baseline activities, there was some funding allocated from contingency
there was.
to cover that.
Ah, good. That's fine. Thank you very much.
Good. Okay, well, I think we've just about reached 11:20, so we'll take that break now. So if I could ask you all to be back in by 11:30, and then we'll restart that. Thank you. Right, we can restart now. So, continuing the theme of recovering waiting lists, we have a general report on restoration and recovery. So back to Oliver again.
So there's covered both elements of it to some degree. So as I mentioned before, we were lucky enough to have a business case approved a couple of months ago for 1.8 million to help us recover our waiting lists. So there's two areas that we are going to be focusing on. The first is procedures, and we're going to be bringing in a company called 18 Week Support to deliver some additional endoscopy activity and also cataracts. So we're going to be starting both of those initiatives in October, initially starting with preoperative assessment, but then moving fairly swiftly into actual operations commencing in November. So the plan at the moment is that we will clear all routine endoscopies that are currently waiting by the end of once 18 weeks has completed its initiatives. And similarly within the cataract side, we're looking to completely clear all of the cataract waiting list, and that will include reassessing all patients on the waiting list and where currently their second eye wasn't identified as requiring a cataract surgery when the patients first were listed. If their second eye is deteriorated, then we will operate on the second eye as well. So that will mean essentially a clean sheet for both endoscopy and cataract services, which is obviously a huge, significant step forward, because they have always been our they've always been our kind of Achilles heel in terms of waiting times. Similarly with Medifer, which is a virtual outpatient provider, we've commissioned 5,000 appointments through Medifer across 7 specialties that are listed below, which have the longest waiting times and the most concerning waiting lists. So they will, Medifer consultants will contact all of those patients that are awaiting a new patient appointment within those specialties. They will, if required, ask for order testing, whether it's blood tests, imaging, etc. And then they will be either seen again by the consultant, not seen, but contacted again by the Medifer consultant to agree a treatment plan, or they'll be discharged on the basis of the imaging or the investigations that have been done, and or referred on to the hospital where there's further investigations or maybe a procedure required. Over the page just gives a quick breakdown in terms of what we're expecting from each of those in terms of referral routes, whether it's discharge straight back to GP, enter what we call virtual hospital, which is essentially a second virtual appointment, a follow-up, or refer through to the outpatients department. So that will again significantly reduce special waiting times within those 7 specialties. What we don't want to do is spend all of this money and then essentially slide back into the same position over the course of a year or so. So we are putting in place quite a significant amount of safeguards to help us improve our productivity and efficiency. As we mentioned before, around DNAs and improving the way that we the attendance at appointments, because we lose probably about 10% of our capacity every year, which is probably about 15,000 appointments every year through DNAs, which is quite a significant amount, and we're going to improve the way that we book clinics. We're also going to concentrate more on how outpatient clinics actually work. So each outpatient clinic has what we call a template, which is basically how many new patient appointments there are and how many follow-up patient appointments there are. We'll look to reduce the number of follow-up appointments within each clinic and increase the number of new patient appointments. And that will obviously provide more capacity for patients who are newly referred from GPs. That is something that the NHS has been working on for quite a number of years to reduce what they call the new to follow-up ratio, and that's through either employing or making better use of clinical nurse specialists, but also just looking at how consultants actually or other junior doctors actually manage their clinics or manage their follow-ups. We're also going to undertake a large clinical and administrative validation exercise. So we know we have over 10,000 people actually waiting for a new patient appointment, but we don't actually know whether all of those people are actually waiting for a new patient appointment. Some people may have moved off the island. Some patients may have had their symptoms resolved either by another specialty, or their symptoms may have resolved by themselves. So, for example, there are occasions where if somebody has a musculoskeletal problem, they might be referred to the orthopaedic surgeon, the rheumatologist and the pain service together. But if they've seen the orthopaedic surgeon, they might not need to see the pain specialist or the rheumatologist, so those referrals can be cancelled. And so we have to go through that quite a significant period of clinical administrative validation, and also we'll do within some specialties a clinical validation, so consultants will be contacting patients to clinically validate whether they still require either a new patient appointment or a procedure. And all of that will be contained within our access policy that is in the process of being developed. We're looking to get that to our Executive Management Committee at the end of October for ratification, and that will essentially be our Bible of how we manage our outpatient appointments and our waiting lists. I think that's about it. Thank you.
Okay, thanks, Oliver. Well, I've got a question. I'll come to you in a second, Vanessa. I've got a question which I think is probably for Sri rather than you. I want to ask about clinical prioritization. And you've just given an example of how you've singled out breast services, put extra effort into getting the 2-week wait back restored. And now we're talking about all the rest of the services, but surely not all are as urgent as each other. Is there any plan to prioritise areas, and if so, how would we go about doing it?
And Chair, you know this, there is a lot of debate about how services are prioritised across the country. We already know that. There's been a lot of debate about the fact that how resources are allocated depending on the priority as well. So certain specialties such as neurosurgery, for example, do not get the same attention as something like breast that would get more, but the fact is that it does not follow the same criteria of prioritisation. I think in living in an island like this and with a system like Manx Care, we've got that kind of slight maneuverability that we can use. Clinical judgment can be used to prioritize as such. We do not have a standardization technique that we use across the system, but I think it is something that we need to work with our partners in Liverpool to see what exactly will work towards it. But actually at the moment we are struggling with what should be the priority in what way, and because we know that certain weights in certain other cancers are increasing while other things are it's mainly to do with the resource allocation as it was. I suspect that your questioning is the fact that how we are going to be allocating the resources, or is it?
Well, like I said, you decided that the breast weight was a particular case that was worth the special effort. By what criteria would you decide anything else is really what I'm asking.
Yeah, there's no one thing. It's just the pure volume that NHS UK has actually picked it up. But actually you're right. There's lots of other specialties and other cancers are equally important for those patients, and they do not fall under the same umbrella.
Okay, so Vanessa's next, then Nigel.
Yeah, thanks for that, Oliver. My question just relates to follow-up appointments, outpatient follow-up appointments, and I welcome the fact that you said you are trying to reduce those. I just wonder if it's worth a piece of work or a bit of sort of self-challenge with clinicians in particular about the appropriateness of all follow-up appointments, because there may be lots of people with chronic conditions who do need regular follow-up appointments, but there may be quite a lot of people who've had straightforward surgery, and the follow-up appointment just means that they come to the clinic, they see a doctor or a junior doctor, and then they just get signed off, yes, you're okay, and there was actually no real need for them to come. And there needs to be something, I think, in place where people have got some problems, that there may be a dedicated number or going back through their GP. But I just think there might be, it's worth asking the question, is there a high proportion of those general elective type surgery procedures where actually a follow-up appointment is probably a waste of their time and a waste of our resources?
Mm-hmm. I agree completely, and as part of the...
Again, I think this is probably one more for Sri, isn't it?
Yeah. So, Outpatient Transformation Program, which is a part of the Transformation Board, is looking at how we prioritize the outpatients. There are new pathways that are there. We do know from a lot of evidence that 1/3 of the patients who come into outpatient clinics as a face-to-face appointments do not need to come into the appointment. So we do know that. So I think building up effective pathways as to how we actually divert these patients to one such is the patient-initiated follow-ups, virtual appointments, and how we have to work with the system and everybody else to develop those. So I think individual specialties are working through their pathways in their outpatients to how we actually reduce this kind of face-to-face or virtual time as it was, or to reduce the footprint across the pathways, across the outpatient. So you're absolutely right. There's a lot of scope for efficiency, and it's a work in progress.
Thanks, Sri.
Thank you. Nigel?
Thanks, Andrew. Through you, yes, for Oliver, really. And it's a question surrounding the use of technology, really, in that, look, through this dreadful period that we're living in and have come through, we've all had to upskill in technology. And as a grandparent, I know only too well that I've had to get my act together on Zoom, WhatsApp, Teams, and whatever other sort of technological communication methodology there is out there. So it really surrounds the validation question and the follow-up appointments. Are you seeing that with this general acceptability of ways in which we communicate, are you seeing an opportunity here for actually where we're validating and where we're maybe doing follow-up appointments for people, and even older people, to be much more accepting of technology and much more open to follow-up appointments and validation on the phone and via Teams and via Zoom? Certainly I've had a number of telephone calls with my GP practice, which have been immensely good and very effective, and seem to me to be a really efficient way of communicating.
Yeah, so during the pandemic, we had to significantly slim down our outpatient work just to maintain social distancing. For example, Nobles Hospital, the outpatient waiting areas aren't particularly big, and to maintain social distancing, you significantly reduce the number of people. So we did move to a lot of telephone appointments within certain specialties. It's not always possible, particularly surgical specialties, not always possible to go to telephone appointments, but certainly the medical specialties we did. In many of those we've carried on. So diabetes, for example, is continuing to do a lot of its follow-up appointments over the phone, particularly those patients who have got the continuous glucose monitoring, where the data can actually be downloaded into the computer and then uploaded by the consultant. I know that's something that Sally does quite often. It's really successful in terms of revolutionising that kind of how we manage, how we kind of transmit data to consultants, and how how the consultants or the other doctors are responding to it. And it's certainly, I think at the moment we're limited to telephone appointments so far. We do have some telemedicine services that are in place now within oncology, particularly as we move towards the Clatterbridge at Nobles model. Most of the appointments that are done with the Clatterbridge oncologists are telemedicine, and people have the choice to either engage with the consultant either at home or come into the hospital and have it telemedicine within the clinical environment. So it's definitely something that we're looking to embrace. But you know, it's there's platforms that have been adopted by the NHS, such as Attend Anywhere, that we haven't really properly looked at here, but I think that as part of the digital transformation programme, that's something that will definitely be looked at as part of that.
So my only plea would be faster, please. So let's not slip back, you know, let's embrace and get on.
Yeah.
Okay, thanks. Andy?
Thanks, Chair. So my question really is around sustaining the elective performance part. So the report by Alan Wilson is very clearly laid out. And then we get to the sustaining performance bit and it says we plan to develop an elective pathway role, when actually what that is to apply the metrics which are above, which are so well set out, you could easily substitute algorithm, and therefore we don't necessarily need to continually recruit more people. So I think realistically we should be looking for more transformative change in terms of how we might address some of these. To me, that's a perfect example of where you could be much more efficient by using what we've already got and actually applying some logic to it. Because the logic's there effectively, and I think, you know, the fact that this report is here means that we've agreed with the logic. I mean, the report on this and the way it works sounds very, very good, but I think moving forward, we don't necessarily need to develop a role for yet another person. I think we should be able to absorb that using tech.
Yeah, no, I wouldn't disagree with you. I think we do need to look at the way that we manage our waiting lists. And that, I agree, that doesn't necessarily need additional people, because we do have quite a lot of people working within the kind of clinical, secretarial, administrative side. But it's something that we want to look into. You know, from an elective, so in terms of our capacity to do more operations, as Teresa mentioned, we've jumped our first hurdle around our theatres transformation project, which is around the AFPP, the Association for Perioperative Practice accreditation, which has come back. And now that we've assured ourselves that our theatres are safe, we're going to start looking at the productivity side of things. So like I was saying earlier around the 6-week, you know, we know that consultants will cancel book their leave within 6 weeks notice, at least 6 week notice. So we know at least 6 weeks before that a theatre list is empty. So we introduce better systems to try and get that theatre list filled. And also for those theatre lists that are already happening, using the data that has been collated over the last 5 years of having theatre man operating in terms of how long it takes each individual consultant to do a particular operation, we can determine or plan with good accuracy about how long a theatre list as it's planned will last. And we can say, well, on the basis that you're doing X, Y and Z, you've got 45 minutes left. Let's put a day case in there. That's something that we don't necessarily have the intelligence to do at the moment, but the data is there, and I know that that's something that is going to be looked at as part of the next phase of the Develop Consulting project.
Thanks. I mean, it just seems obvious that we can be smarter.
Yeah.
If we got to this point, we can be smarter.
Okay, next, Teresa.
Yes, it's more of a comment really, and I don't think we should underestimate just how significant this new access policy is going to be for Manx Care. There has never been an access policy previously, and I see it as a two-way process. It's our contract with the public as to what they expect in terms of access standards from Manx Care, but also we're holding ourselves to account on it. And we're asking the public to work with us and comply with us regarding those standards. And I think in terms of what we've discussed this morning, we've talked about patient-initiated follow-up, the use of clinical and administrative validation, capacity and demand, digital transformation supporting a different way of delivering our outpatient services. And I do think there is significant change linked into that access policy, new pathways. So I feel it's a fundamental time where we need to do some more communication based on that policy with the public, so they understand what this means, what changes this means, and so they can help us make sure it's delivered sustainably, and they understand what this all means. And I think, it will need extensive internal communication, but I also think we need to share it really widely with the public.
Sri.
So, just want to kind of make a point that before we started off this program of recovery, restoration and reset program, we had 5 kind of main points, and I like to think that we've met all of them. The first point is the fact that we were going to have an honest conversation with the public with regards to non-COVID care and the backlog and the system that needs to support it. We are having it, one. We are making sure that the health and safety and the mental well-being of the workforce remains our priority, which we are doing at the moment. We've actually asked for additional resourcing for our backlog, tackling the problem itself, which we've asked. We've also asked we are putting measures across to expand the system capacity itself. And the one final bit is about retaining the medical workforce within the system, Manx care. So we are actually doing all those 5 principles by actually this policy itself. So I think I'm reasonably reassured that what it was set out, it has got all the principles embedded in it.
Thank you, Sri. And the final word goes to Doreen.
Just 2 points from MCAL's point of view in regards to the did not attenders, the DNAs. That maybe an option clinically is that if they don't appear in clinic, that they're given the patient is telephoned, and given a virtual appointment. If they don't answer, then they're written to and maybe given 2 weeks to get in contact with the department. And that way then you don't go into wasted spaces. And it's something that we've utilised in the past, I have done clinically. Also that patients who are waiting, who are contacting MCALs, would like to know about their scan results, blood results, within a time frame, not be left weeks waiting for 6-week follow-up appointment. Again, that can be pulled, written to swiftly and save a lot of time and energy for everyone. So I think that would be effective.
Some good ideas there. Thank you. Thank you, Doreen. Okay, right. Now we're going to move on to what we've already flagged as being a major concern, the staffing report. Sue, I think you're going to take this.
Thank you, Chair. Just to start off with the Executive Director of Nursing, Volume 4, presented this paper which you've all had circulated. This is really a culmination of executive walk rounds. We benefit from a very highly visible executive team now in Manx Care, which we welcome. And in addition to the walk rounds, the Director of Nursing also attended a number of bed meetings which we have at the hospital on a daily basis, 3 times a day. And at those meetings we look at the number of emergency admissions we have, the number of planned admissions we have. We look at staffing across all of the inpatient areas. And he also did an analysis of our rotas during a month of September. His paper sets out his findings that there was a high level of volatility really in these rotas, and there are variations in the way the establishments are in place across Nobles and Ramsey Hospital. What I mean by establishments are the numbers of registered nurses and healthcare assistants that make up the workforce for any given area. His paper also talks about acuity and dependency, which I've just briefly described. That's where we look at a patient, and depending on the level of intervention that we need to do to care for them, they can have a score. So there are models which we can use, tools which we can use to score patients' dependency. For example, if a patient has intravenous fluids, a blood transfusion, a wound from an operation, they will score more and more points, and that will give a patient an overall score. Our executive director established that there hasn't really been a robust way in which nursing establishments have been undertaken for Nobles and Ramsey hospitals in the past. There's variation in whether something called uplift, which is a percentage that you can use. It's usually around about 23 to 25% of the workforce, which is added to the establishment to allow for absences such as sickness, maternity, Some establishments have that, some establishments don't. On the ground, the nursing workforce are clear that as they've been flexible over the years with staffing to support their colleagues who may want to temporarily reduce their hours or permanently reduce their hours, sometimes those hours appear to have been lost in our systems. So there's a degree of erosion of establishments there as well. So this leads to really what he describes as a very volatile day-to-day way to run our business. Significant time and energy is spent each shift, I would say 3 times a day, not just daily, by matrons, ward managers, senior nurses in moving our existing resource of staffing around the patch just to address what I would describe as minimum safe levels of care. The result of that is that brings everybody's baseline down to a minimum. Coupled with a number of other things, we really struggle with recruitment, like all jurisdictions. There's a big hole in terms of recruitment of nurses, and everybody struggles with that. We're fishing from a very small pool. For example, in the UK, we train really quite small numbers of nurses on the island. We have that facility. We only train on average about 12 registered nurses a year. It's a 3-year training programme. And if we couple that with the fact that we have an ageing workforce, and we've projected figures around that, and Paul's put that in his paper here, showing that currently, if we take the age 55 as a point in time that a nurse could retire, should he or she choose to, 28% of our workforce could currently retire today should they choose to. Even more worryingly, that projects it to 47% by 2026. So there's a significant risk now and in the future. And I think Paul's paper is really compelling the board that we really need to take some immediate actions, some short-term and long-term actions, which is set out in terms of across page 3 and 4 of the report. So his immediate response was to continue to try and utilise bank and agency in the best way we possibly can on a day-to-day basis. We've also identified a number of non-ward based registered nurses. For example, I'm one of those, and looking towards that group of colleagues to support some of the gaps in our existing rotas. We have got some links into organisations that can help us with international recruitments. We've already recruited 8 nurses from the Philippines in recent months. We've got around about 9 to 11 in the pipeline from Africa. We really need to accelerate and progress that programme. Paul's view is we need to significantly increase the number of nurses we can train on island. So, for example, this year we were turning people away. We had a higher number of people who wanted to get on our registered nurse training programme than places we have. And we really need to maximise that desire for the public to want to join, to join the nursing profession. And I think really what we're starting to see, unfortunately, is the staff are tired. They're tired for a number of reasons. Probably COVID's played a significant part. We've got an ageing population. Now, doing a 12-hour shift at the age of 55 is a difficult thing to do. And there's less and less discretionary effort apparent to us when we're asking people to move constantly or change shifts. Can you go home and come back and do the night shift? There's only so much of that people can take, and that we should expect them to take. So we need to, take the opportunity now to make some real significant decisions about how we secure our future workforce from a nursing perspective. I would overlay that to midwives and AHPs. I don't think they're far behind. I think that it's a very similar picture, certainly when you look at retirements, protected retirement. So it's a significant issue, and I'd welcome any support the board can give and will give in this area.
Thank you, Sue. So the report identifies the problem. It identifies a number of things that can be done in the short term to improve the situation, and then a number of things that can be done in the long term. So I guess I've got 2 questions for you. From what you can see here, is this going to solve the problem in the short term? I think I can answer that question for you, but I'll give it to you. Is it going to solve the problem in the short term?
I don't think it will solve the problem. I think it will. I think if we think about winter approaching, not that we seem to have got out of winter, I think it's one way of addressing some of the kind of immediate imperatives. I think we're going to continue to have to mobilise our workforce. I don't think it'll solve the issue immediately.
Okay, and the second question is, where do you think is the area of greatest risk?
In terms of patient safety, I would probably say the acute medical wards, the general medical wards.
Right, and is that daytime, nighttime, or both? Or?
Well, it's higher risk at night time because the numbers of nurses are less at night time, so there's less resilience in there for sure. You know, if you have short-term absence or sickness, there's less scope to move the workforce around, particularly at night.
Okay, thank you. Katie.
So obviously this is very worrying. The first thing I would say is that you're not alone. It's prevalent throughout the UK as well. So I strongly endorse the foreign nurse recruitment drive. Oxford are doing that in spades, so I thoroughly endorse that. But so my question really is, are we back to allowing as many visitors as a patient would want? I know we've been through COVID restrictions and not having everybody coming in and out of the hospital, but are we back to open visiting policy? And the reason I ask that is that we have found that when we have open visiting policy at Oxford, it reduces the pressure on the nursing staff because the loved ones are there to assist the individuals to get out of the bed, to go to the toilet, for instance, and reducing falls and things. So can you just comment on that?
I would say that's a really good point, and I think we should welcome carers to help care for patients whilst they're in our care. I guess from the Executive Director of Nursing's paper, I think he's referring to more of kind of the acute, higher technological interventions that nurses are required to do, registered nurses particularly. In his paper, he also talks about upskilling our healthcare, assistants. But again, upskilling them with an associated remuneration around their skill set. So I definitely think carers' relatives have a part to play. I'm not sure how much that would improve the safety of care, but it's a really, really good point, and we should maximise that.
Are we back to an open policy? I'm sorry if I missed that.
I think we are back to.
You're having as many visitors as. Okay.
Oliver probably. I think we're restricted still to a degree, aren't we? Do you know, Oliver?
I think we're still restricted to 15 minutes. I know we've relaxed it in care homes, but I think we've kept it just because we're still running, well, we were up until a week or so ago still running a COVID configuration. I know that we've got a battery of changes to review tomorrow at our Bronze Command meeting, so I'm sure that will be considered.
So that may be a factor to consider. Thank you.
Yes.
I just wanted to thank Paul and you, Sue, for bringing this paper. As Vanessa said, it was raised at Quality Committee, it was also discussed at People Committee. It's obviously an incredibly important report for us to read, and a very uncomfortable report for us to read. I think the mitigating actions in the short term and the medium term, I think, are the right ones. I guess for me, there's something about, and I think you're absolutely right, about midwives are very close behind, if not actually in some cases already there. And I think AHPs are also an issue, and probably if we looked at medical staffing, we're not going to be terribly reassured that that's all fine. I think there is something for us to do as Manx Care about what it's like to work here as Manx Care, which is different from what it was like to work for the department. And I would like to see us, and it's probably more of a medium-term plan, but I would like to see Marita, as the Director of Communications, look at how do we tell the story of what it's like to come and work here, and how do we build into that, the employee voice, the employee offer, how we treat our staff, how we support our staff, and how do we build a kind of campaign, a longer term campaign. And I appreciate it is a longer term, which is why I say I think those actions that are written in the report are the right ones for immediate and medium term. But how do we build that sense of coming to work here in this health and social care system is excellent. We have a vision to be the best small island health and care system. I think we've made some real changes. Some of us yesterday heard from colleagues who were describing a real step change in culture, which was incredibly encouraging to hear. But how do we get that message out there? Because as Katie has rightly said, we are not alone in this, and there are many, many health and social care organisations looking for staff, and I would like us to be able to tell a different story of a supportive culture and, of course, as Nigel reminds us on a regular basis, a beautiful place to live and a fantastic environment in which to raise your family. So I would like us to perhaps have some kind of roadmap of when we're going to get to in terms of that campaign about Manx care, about recruitment, about and of course how that impacts on improved patient care. So maybe that's something we can see at our next board meeting.
Okay, I think Teresa's going to come and sum up. I think Andy first.
Mine's a purely practical point. In the report, one of the items was obviously building, training more of our own nurses, because 12 per annum is going to do nothing other than basically deal with natural wastage, if that. It won't even start to tackle. Do you know, have you a plan for how you're going to assess the size of that change, or is that something that board should be arranging so that we know how many people will need to train to overcome this over a 5-year period?
I know that Paul's looking into that as we speak, and he's liaising with colleagues in Kildare who are the educators who train our nurses. Okay. And I think he's talking about probably doubling or trebling the number of intakes that we need, increasing that to about 60 a year.
But 520 over the next 5 years. I don't think even that's probably going to be sufficient, is it?
Not alone, no.
I mean, you're talking about that would put a very significant stretch on the recruiting overseas nurses.
Yeah.
Is that going to be achievable, do you think?
I think we have to do what we can to address the issue. I think the point that colleagues have made is that everybody is struggling with this issue. So what I think we can do is maximise what's in our control.
Okay, thank you very much. So, Chair, can we expect to see an update from Paul with an estimate of how the size of this problem in terms of extra training?
Well,
next
I'm going to say
perhaps?
Teresa to sum up. Can we put that one to you, Teresa?
Yes, absolutely. So I think there's a few strands to this. It's really imperative we do that establishment and acuity work very, very quickly, but we do know is going to tell us we need to invest in additional registered and unregistered nursing workforce. We need to wrap a very comprehensive piece of workforce planning around that so we absolutely understand what the future looks like. And for those of us who've worked in the UK, this is an industry in itself behind the scenes trying to get the numbers right as to how many you need to put into the pipeline, how many you lose along the way, and how many you need to have coming out the other end. And we do need to do that. We do have the opportunity to recruit registered nurses through an international overseas programme. But Manx Care alone cannot do this. We need to get approval from DHSC and we need to get the support of Treasury. But as it stands today, we do have an opportunity to progress at pace some international recruitment. But we do need to make sure Treasury and Department of Health and Social Care are fully on board with this. So this is something the executive team are already discussing and trying to progress. I think alongside that, we absolutely need to maximise the opportunity of the unregistered workforce. There's a huge skill and talent base in the unregistered workforce which we are not tapping into. And there are people who want to be developed with an extensive skill set up to band 3s, band 4s. And we need to put that programme in place alongside that. Whilst also developing at the other end our specialist nurses who will become nurse consultants and ultimately help with the workforce challenges we have around medical staff. So I think we understand the totality of the challenge, but I think the priority for the executive, I would suggest, is to very quickly, with the support of the board, progress the overseas recruitment with Treasury and DHSC, whilst quickly getting on with the acuity review, which will inform any business case. I mean, we are going to have to probably speculate on the sorts of numbers that's going to be required. And I guess this comes back to a discussion about risk appetite, and just trust that our Executive Director of Nursing is going to need to give us some guidance on that whilst we absolutely nail down those numbers and look at how we can optimise those rotas. But I think we need to absolutely move at pace on this. This is very high risk for us.
So I think the answer to your question, Andy, is yes. And perhaps we can have a plan come to the next board meeting. Would be great. Okay, thank you. Vanessa?
Can I just re-emphasise Katie's point about visiting and ask very specifically that that's looked at about relaxing visiting rules, because I agree with Katie that people, you know, if visitors can be there for quite a while, they can help their loved ones and give that reassurance as well that makes them feel more confident. And possibly added to that, whether or not there's any scope for the use of volunteers on wards, just to be there and around, and even if they're not doing any nursing procedures, they're there to ask another nurse or a nursing assistant if there's a patient looking like they're wanting to get out of bed and in danger, that they can raise an alarm or something like that. So, so it's just building on Katie's point.
Those are both excellent points. So, Sue, if you could just check what the situation is on visiting, and perhaps you could give us a response by email as to what we can do about that, and indeed the point about volunteers too. Right, we're beginning to get a little bit tight for time, so let's move on to the next item, which is, again, staff issues, staff absence report. And could you try and give us a brief report on this?
Thank you. So I just wanted to reassure the board that there will be a more holistic report oncoming. Obviously, this just touches on absence, but I will give a verbal update on some of the other areas that impact on this. So in particular around the workforce and culture team, and I'm working on some reporting with them. So the absence report highlights that respiratory conditions have increased. I think that correlates with the experience of the hospital seeing more flu. I didn't speculate on the reason for that, but I'm guessing the relaxation of some of the social distancing has had an impact on that. The other areas, we have high levels of absence on musculoskeletal and the mental health, stress-related issues. That's common in most employers across most sectors. And there's been a number of actions put in place since it was recognised the impact of COVID on health and care staff particularly. So the mental health service was involved in putting on training for mental health first aid. That's quite high level training and awareness for managers and how to deal with issues. There's also more general awareness training that's offered to managers and staff. There's the Headspace app was made available to care staff. I don't know, we haven't re-emphasised that lately, so I'm not sure how many people are still currently aware of that. There's also a specific helpline for doctors to support their mental health that's available. Other things have happened. There's a Stress Awareness Month in April, which offered 28 activities, and some of things around mindfulness, exercise, hypnotherapy. Mindfulness sessions have been offered by the welfare staff, and the other thing I would just mention is that the health and safety team were looking particularly around musculoskeletal issues and been working with managers to reduce those, and were quite reassured that that appropriate actions were being taken. So I think all those things I've mentioned tend to relate to long-term absence. So, and the best advice for long-term absence is that prevention is better than cure, and that as soon as somebody becomes absent with a condition that could be long-term, early intervention is better than later intervention. The longer an absence goes on, is the more likely it is that somebody won't return to work. So the other piece of work that HR is particularly involved in is supporting managers to manage absence. So the HR advisory team meet with managers regularly to review their absence, and that's to make sure that the absence is being monitored and that staff are being supported and contacted, and back to work interviews and those kind of things are happening. Again, the evidence is that those kind of interventions will impact on short-term absence. So I think the other thing we need to recognise is whatever initiatives we offer, staff need to be able to take them up and take advantage of them, and I think you've alluded to some of the problems with how stretched our staff are, and that sometimes impacts on their ability to do that.
Just one question, and some of us yesterday were meeting with various managers. We met the head of operations, who talked about the high level of sickness absence amongst those staff, was asked what he thought was an important factor, and he said he thought it was childcare issues. it was suggested that we might look into creche facilities for healthcare staff, and he said he'd take away and look at that. I don't know if you've looked at that yourself at all.
It has been looked at. Plus, Barbara might be able to comment on that. Barbara, you were certainly involved in a project around health creche facilities, weren't you?
We've looked at it several times over the years. The last time, probably about 2 years ago, I would think, thereabouts, there wasn't a need expressed by the staff that they wanted creche facilities at the hospital. It was more that they would prefer them in their locality, and it was the lack of under-2 care that there was the problem. However, the numbers of childminders was quite high, and the vacancies within childminders was high as well.
Sure. Well, it may be worth another look, mate.
It might be worth doing again.
Yeah. Any other questions for Anne? Okay, let's move on to finance then. So over to you, Jackie.
So yes, the management account obviously has been circulated, so just a couple of highlights. The main thing to point out from this month's report is the movement in the forecast. We've seen an adverse movement in our forecast year-end position to a deficit of 5 million. So I just wanted to talk through some of the things that are driving that and try and explain where some of them are things where we have control over it, on other areas where we may have less control over it and might have to mitigate in other areas. So the main reason for the move in the month in the forecast is that our tertiary activity data has come through, and it's showing a significant uplift in activity. And we expect that that's as a result of a byproduct of the restoration and recovery activity that's happening in the UK. So our patients are being carried along on that wave, and obviously those activity levels would be higher than we had anticipated. So there's a piece of work being done at the moment to try and pin that down to see what that uplift looks like, because obviously if that's sustained throughout the rest of the year, then that could create a significant pressure for us. And obviously, you know, we wouldn't want to go down the route of having to say to tertiary providers, you know, treat our patients differently. We want them to be borne along on that wave, and to come back to what Oliver was saying earlier on about the restoration and recovery more broadly. So that's one area that we're looking at. The other thing that continues to provide pressure on our costs is the increasing drugs costs. And we're experiencing pressure across the system, across medications, across specialities, and that's a global phenomenon that's happening. So there's very little we can do to address that specific growth. What we are doing is, through the SIP program, is trying to mitigate. So we're looking at prescribing habits, we're looking at wastage, and we're looking at ways that we can minimise the impact of that. But it's worth emphasising that we have little to no control over what the actual drugs costs are. And I think we're also seeing an increase in the use of PPE as we continue to move along. So the other big pressure within the system is the cost of COVID. And I know we've got an amount built into our forecast of about 1.4 million, which we intend to submit a business case to Treasury to seek funding for. However, I think that 1.4 million relates primarily to things, the obvious stuff, such as PPE, testing, swabbing, vaccinations, all of those sorts of things. But I think there are a lot of other costs that exist around the organisation where we've had to incorporate stuff into our baseline or expand provision. That's less obvious, and I know that Oliver's doing a big piece of work on that to try and really get a handle on what the quantum is, because I suspect some of the run rate overrun that we're experiencing is partially driven by increased costs as a result of, you know, COVID measures and mitigations that we have to put in place. So, you know, if we've got social distancing or we've got to have extra rotas. It's interesting, when we looked at Anne's report, you can see that there's an actual cost of COVID-related absence. So whilst the cost in the report is based on what the staff costs are, the actual costs of the organisation of covering those absences is actually likely to be higher than that if we have to cover it with agency or locum staff. So again, it's just a piece of work to try and work out how much of our overrun is COVID-related and how much is other things. The other thing that is driving, a big driver in terms of our overspend, is obviously our private patients unit. That's a big impact to us in terms of not being able to open that unit. I know we've been looking at various options, but because it forms part of our escalation plan, we are limited in what business we can put through there. So in terms of mitigations, obviously one of the major pieces of work is that seeking additional funding to cover the impact of COVID on our system, so that we can clearly see what's left is what's actually happening in our underlying system. Our SIP project is moving at pace. It's, as any project would do, it's facing its challenges and its risks, but we're confident that we can meet our target. We initially started focusing on 5 areas, 5 work streams, and that's well advanced. So now we're looking at other areas wider across the organisation. So when we chose these particular work streams, they were regarded as the easier to get at, low-hanging fruit, so to speak. But we knew that there were lots of other opportunities around the organisation. So rather than adopt a scattergun approach, we decided to focus on a number. And now that the work is advanced on those and progressing, we'll start to move and look at other areas around the organisation for potential savings. One of the other areas that we're looking at is our patient transfer service, so our off-island patient transfer service. Now that we're in conversations with assigning a contract for that, that changes the contractual basis from a block booking arrangement to an activity-based arrangement, and that offers us opportunities for savings as well. So again, we're just working out the quantum of that, because obviously if our tertiary activity in the UK is going up, that will generate an increased off-island transfer service as well. So we're trying to link those two pieces of work together. But I think the other area around SIP in particular, and it's been mentioned and talked about in various guises throughout the day, is that there's many requirements coming out and becoming evident, and a lot of pressures where, you know, everything we look at, we think we have to do that, but obviously we have not enough to do everything. So I think we've got some difficult decisions to make around how we prioritise our resources. But equally, and I think it's really encouraging to see, and I'm seeing it borne out through the business case review group conversations and through the SIP programme conversations, is that there's a definite acceptance and an embracing of this idea that we do more with what we've already got. So rather than we see a problem, we need additional resource. The first action being we need to bring more staff in. The first question is, well, how can we rearrange our resources to do more with what we've got? So I think there's an enormous amount of work going on around the organisation, so that whilst we're not saving money, we're actually achieving more activity with the same level. And sometimes that can be difficult to see, and sometimes it can be hidden by the bottom line, which is a negative. So it's important to take the projected overspend in the context of some of the other activities that are happening around the organisation to achieve efficiency. So a big piece of work that we're doing at the moment is a more formal, what we call our back to balance plan, which is what actions we are going to take to try and bring us back into line by the end of the year, bearing in mind some of the pressures that I've talked about.
Thanks, Jackie. Well, as Nigel said, this has been quite heavily scrutinised at the Finance Committee already, but are there any additional questions for Jackie? Sri.
Jackie, like you've just heard from our paper nursing staffing issues, and we are only 4 or 6 months into establishment Manx care, and there are new things that are likely to come up as we go along. Is there something like a system or sustainability or resilience fund or anything in the Treasury that we can access or support? Because it would be kind of, I think, experience, and you probably will know for yourself, but this is not likely to be the end, isn't it? There will probably be needing more support money anyway. So do we have that kind of access at all?
So the short answer is no, there isn't a specific fund set aside for that. If we wanted additional funding, then we would have to go down the route of submitting a case to Treasury. So that's what we're doing with the COVID costs, and I think if we can capture that and get that right, I think that will take a lot of that financial pressure out of the system. And again, you know, we can utilise that, and I think a lot of what we've got to try and do with these resources and this funding is to try and bring some stability into the system, because there's a lot of instability and a lot of volatility out there. But I think if we were to look to seek additional funding, personally, I think we would be better off trying to provide a case for a range of interventions rather than piecemeal. We need money here, we need money for that, we need money for that. So whilst it might take a little bit longer to pull together, I think a more strategic view of what might be required might be a better approach. And I think the difficulty with that lies in that these issues and these pressures are constantly emerging. So when you think you've got a handle on what you might need, something else comes out of the woodwork and you've got to add that into the mix. So we just got to keep that one under a review. But I think we really need, as an organisation, particularly if seeking additional funding is not really where we want to go as an organisation. I don't think it's what we want to be doing. And we really need to be able to very, very clearly demonstrate, if we're seeking additional funding, what have we done to improve our efficiency, to save money, to increase activity, to redeploy resources, to stop doing things, as Nigel mentioned earlier on. And that's going to be our challenge, is trying to do those things at the same time.
Okay, Andy?
I just wanted to make a comment rather than ask a question. I think the summary, Andrew summarised it, I think, if I remember right, in the Finance Committee, that while it's legitimate for the excess for COVID-related, if you like, the PPE particularly, where we absolutely have no control over that, it's absolutely required by the whole of society, it's entirely legitimate to ask for that back, if you like. But the other bit, we should take it on the chin. We really should, because that's one of the reasons we were set up, is to be good financial citizens, to look after our own budgets, not to keep going back and holding that out for more money. We need to live within our means.
Absolutely agreed. And I think that the temptation in this situation is to say we need more. And I absolutely agree with you. And it puts us in, I think, in a very, very challenging situation, because I think the expectation very clearly from Treasury is that we and DHSC together will make some difficult decisions about priorities, rather than simply seeking additional funding.
Right, and as usual, give the last word to Teresa.
Sorry. So it's sort of a comment really that I guess Treasury see us combined with DHSC. So I do wonder whether we need to have some transparency through the board papers on their financial position, because I know Treasury look at us as the totality of Manx Care and DHSC combined. And I guess my second point is just, I think, where we potentially do have the opportunity, coming back to Cherie's point, is where we can link it back to transformation. Because I think in the dialogue sessions that Andrew and I have been having and through the Transformation Board, there is an acknowledgement of where the baseline might not be where people thought the baseline was. And we've needed to sort of reevaluate and reassess that as things have emerged. And there is, it's not a given, but I think there's certainly an opportunity for dialogue there about where we would need to put something right first before we start the transformation programme.
Okay.
If I could just, I'd absolutely agree with you there, Teresa. I think there's a blurred line sometimes between what's business as usual and what's transformative, and sometimes just getting to business as usual is the transformation, and I think that's a piece that's probably been missed up until now.
Right, we are nearly at the end of our time, and I do want to get to these questions from the public. So there wasn't any other business, so I've got 5 questions in writing, so I'll give those plus the answers. 4 of them are from our friend Mr. Mann, so welcome. And they're all about GPs. So the first one is, I recall I asked a question as to why GPs could not do their training out of the normal working week, thus avoiding shortfall in appointments. Could you please confirm this question will be put to the board? So the response is, it's not really an expectation that any training is undertaken in people's own time. However, GPs do a substantial amount of training in their own time. The GP education session is an absolute necessity. It's a time when the GPs can get together to undertake central training. This is going to become more essential more often as we move into transformation and moving services from secondary to primary care. So that's the first one. The second one, having noticed that one of our local GPs had the time to take the entire day off to support Dr. Allinson in his re-election, could you also ask the question as to the circumstances that enable a GP to be absent from work during the working week, say for annual holidays and sickness? Reply, GPs are not our employees. The likelihood is that the GP took the day off as leave or did it on their day off. We will check with the practice. Without knowing which GP it was, that's quite tricky, but we can generally ask around. So maybe you could help us outside on that one. Third question, could you please ask as to why the consultant pension scheme are not currently transferable to the Isle of Man, thus putting off the recruitment of key staff, and what steps Manx Care have taken to rectify the situation with the DHSC? This is a really, really important question, this one. But unfortunately, the UK NHS pension scheme is an occupational scheme only available for contribution for those working for the UK NHS. A consultant moving to the Isle of Man can transfer the value of his UK pension into the Isle of Man government unified scheme, which would be valued based on actuarial valuation. And the Isle of Man NHS scheme closed in 2012, and at that point people moved into the unified scheme. And the fourth question is, could you please ask for a report on what steps have been taken since the last Manx Care meeting to substantively improve the provision of GP facilities at Ramsey Group Practice and to update, redevelop Ramsey Cottage Hospital? So we've got a reply from Barbara, but I'll read it on her behalf. Regarding Ramsey, the hospital has continued with the planned maintenance programme. The electrical infrastructure has had a new generator installed and UPS... Sorry, Barbara, what's UPS?
Uninterruptible power supply.
Oh, right.
Big battery.
Big battery to support the critical elements. To support the critical elements of the hospital. Reviews continue to look at the use of the various buildings, and a long-term plan will be considered in due course. And then in relation to the GP facilities, the premises are GP owned, but they've done quite some work in their premises in the last few years, and we're not aware of any particular shortcomings in the GP facilities. Then there's a separate question which is not from Mr. Mann, which came in too late to get a planned answer, so Teresa's going to take this one. It's a common issue with integrated care pathways that finances do not keep track with the development of care pathways. How will Manx Care ensure that this does not occur, and how do we ensure that the finances flex with developing care pathways? And this comes from somebody in the CAMS service.
Yes, so I'm going to sort of try and apply it to CAMS because I'm guessing Mark presented this question with that in mind. I mean, I think Manx Care does have the ability to move money around the system and its services, and that's a fundamental which will allow us to redesign care pathways, and hopefully the money follows the pathway and the patients. So I think that's the sort of the first principle. I think if you apply that specifically to CAMS, we are looking at a very different service model and delivery called I Thrive, which is about moving patients downstream and becoming less reliant on CAMS by putting early help and support. And that requires us to work with the Department of Education and Culture. So we're doing a lot of work with DESC to understand what that looks like outside of CAMS and in the school setting. So that would be somewhere where we would both put funding into the pot for the delivery of that service. We would then configure a model around what does core CAMS look like, and I know there'd be a strong social care element in that, so there would be health and social care contributing to the delivery of that model. And hopefully that means we can start to reduce the level of spend around inpatient provision and those high intensity cases. But I think the fundamental principle is Manx Care does allow us to move that money around the system where we feel there is a different service model available to us which will have benefit. But equally, in that wider government piece, there is the opportunity to work with other government departments, and education is key in this particular model.
So I think we're grateful to those people who gave us questions in writing, because that gives us the opportunity to research them and give good answers. But there is still also the opportunity for anybody to ask a question now. So anybody from the public want to have a turn? Mr. Mann, you want to? We have organised a microphone this time around.
Thank you. It's more just to be able to give the board the benefit of one candidate in the last election. I noticed that out of 64 65 candidates, I'm the only person who's actually bothered to come here to give you a little bit of feedback. I'll only take a few minutes, because the feedback from the public fell into 3 categories, and they're quite interesting categories. The first is that the telephone triage system that's been adopted by the GP, certainly in the north of the island, but I think it's actually common across the island, is failing because it's not operating. Some parts of it are really successful, but it's being seen as a barrier between some patients and their GPs, where they don't feel that the access is actually as quick and as rapid as it should. Which then takes me to the second issue, which is the shortfall in mental health. We had one person who attended a meeting and actually very clearly mentioned that she'd lost 4 of her friends in the north of the island in a year through suicide. And it then became apparent that there isn't a swift way of a mental health patient accessing the first stage of any kind of mental health facility. And that runs in tandem with the position over the telephone triage system, because if you are a mental health patient and you ring up in crisis and you get the kind of response that actually every other patient gets from the GP, you may well come off the phone, and unfortunately that may be the end of the matter. So I think there is actually some mileage for having a mental health crisis line that avoids the GP surgery as the first point of call. And the third issue is a lot of people have recently seen the position with the shortfall in nursing and the difficulties at Nobles as actually seeing the hospital being in crisis. Now that may be the collective effect of what's happened with COVID. It may be the collective effect of what's happened with the shortfall in consultants and the collective effect of all the general things, the lack of finance and so on. But to reach the stage where the public are actually seeing what's actually happening at Nobles as being in crisis is actually quite a turning point. I did have one individual who quoted to me a patient who'd, first of all, there was a delay in the ambulance. Secondly, when they got to Nobles Hospital, the patient ended up sitting for a considerable period of time in considerable pain on a trolley because one of the wards had been closed down through a shortfall in nursing. And so I think sitting before everybody here is the sharp end of what I've seen. And if we look at the money side of things, it is now time to project that out to the new government to say, actually, you're going to have to spend a sum of money. It's not about saving money now, it's about saving money later on, but you're going to have to actually spend a sizable sum of money in bringing forward the initiatives which we've heard all around the table. Without the money, they're going to go nowhere. And thank you for the time.
I mean, I think I'll ask Teresa to come in just a moment, but I think in your last question, is it a crisis? I mean, I think you've heard a very honest discussion around the board table today about a system that's under great pressure, for sure. Shortage of staff in some areas, long waiting lists in other areas, difficult to recruit in some places. So I think you're right to point to it being under major pressure, as indeed are health services throughout the world, very largely as a result of the extra pressure from COVID. I don't think I would agree that it's in crisis based on what I've seen walking around the hospital and visiting the wards and speaking to people who work in the hospital. Yes, pressure, but not crisis. But this is something that this board is going to keep a very careful eye on, for sure. Teresa, do you want to pick up either on that point, the mental health crisis line, or the GP telephone triage?
Yes, if I just start just confirming, we do have a mental health telephone crisis line. So it's a dedicated crisis response line directly into mental health. So members of the public, patients, don't need to go by their GP in order to speak to a mental health practitioner, and that line is available 24/7. Perhaps what we ought to do, if there is a perception that they have to go through their GP, is make sure we are publicising that number and people do know how to contact that service. I would agree with the chairman around the hospital being in crisis. I don't think it is. I do think it is under pressure, and I think that's partly because of the staffing shortages that we've discussed very openly today. But I also think we are working very hard to transform our services and putting a number of measures in place which ultimately improve safety and provide a better experience to our patients. But and we are managing that really, really closely. So with myself and the rest of the exec team are very, very connected. We do very regular walkarounds. We have been operating under a command structure arrangement all throughout COVID, and that's still in place, so we understand the feedback from all of the services and all of the care groups on a really regular basis. So we understand the pressure points in each one of the services, both within Nobles, but across the whole suite of services delivered by Manx Care. And, you know, I think we're here as a board, aren't we, to balance those sort of quality requirements, financial requirements. We can absolutely see where we need to make some of those changes, and we are in regular dialogue with DHSC and Treasury and Transformation regarding where are the priorities for investment. I think over the last 6 months we've had some wins around the restoration and recovery funding. We know we've got a really strong submission that's gone in around our budget setting process for next year, but inevitably a new organisation will always find new things where we didn't understand the baseline as well as we perhaps needed to, and we will need to make some amendments and changes and respond to some of those challenges which arise, of which, you know, the very obvious one today that we've discussed in detail is the nurse staffing issue, which our new Director of Nursing with his fresh eyes has been able to articulate and capture the whole views of what people have been saying for a while, but describe it in a way to the board which means that we can now take some action on that.
Thanks, Rita. Anybody else from the public wish to ask a question? No? Okay. In that case, thank you all very much for coming, for showing an interest in our board and in the work we do, and wish you well and see you in 2 months' time. Thank you.